Thank you so much, Ashu. And absolute pleasure to be here, Dr. Kataria and Deepak. Thank you for the invitation. I'm really, really grateful. I assume all the audience, at least majority of them, are radiation oncologists. So I'm going to be addressing this to a radiation oncology audience. I have to talk about SBRT in prostate cancer. And this is the brief that I have been given by Dr. Kataria as a guide to what all I should cover. I will do my best to cover all these things. I may not be in the same order, but I will not only try to cover this, but also try to show you some of the challenges that we have faced in establishing and propagating SBRT in prostate cancer, specific to the Indian demographics, certain challenges, and not only that, how we've tried to create evidence that all of us can use in our practices, and also touch upon some of the practical aspects of doing things or not doing things, etc. And I'll leave enough time for discussion, I promise. We cannot start an SBRT talk without talking about alpha beta. Now, I assume everybody here knows that the alpha beta, the radiobiological parameter, is low for prostate cancer. And this was very prophetic. March 15th, 1999. This is just a couple of weeks before I joined my first year MD in Tata Hospital on the 1st of April. So, I mean, I just realized that now. I had not read this paper that time, obviously. Brenner and Hall, they predicted that because the alpha beta is low, I have highlighted it here, prostate cancer treatments can be designed using larger doses per fraction, and such schemes would be expected to maintain the current levels of tumor control and late sequelae. Remember that, maintain current level of tumor control and sequelae. And I'm saying prophetic because of this. That is exactly what happened 15 years later. The CHIP trial, which showed us in a randomized fashion, nearly over 3,000 patients comparing conventional fractionation to moderately hypofractionated radiotherapy. They wanted to show similar outcomes. So this is a non-inferiority trial, less than 7% reduction in local control and similar toxicity. That was the hypothesis. And that is exactly, that was proven 15 years later. Outcomes were same between 74 gray and 60 gray, which were equi-effective doses, and toxicities were, the magnitude of toxicities were similar. Both GU acute was slightly, GI acute was slightly higher, but you can see here, this is the grade 2 toxicity, very similar in between normofractionated and hypofractionated. But we as a community really, we love to move on, don't we? We love our technology, we love our machines. And this is a very popular meme doing the rounds in the social media, very appropriate for this day and age. So we've kind of established the world. We means, I'm saying the radonc world, not us. Moderate hypofractionation. Now we need to move on. That's what we think. And let's see if it is the right decision or not. SBRT is a dose per fraction that is generally considered more than 5 gray per fraction. And the idea is to improve therapeutic ratio, shorter course of treatment. It is more convenient to patients. It is cost effective. Well, is it? That is something that we are also studying. Clearly, from a patient perspective, they have to travel less. They have to stay in cities like Delhi and Mumbai for a shorter time. And in a very, very busy department like us, we get buy one, get one free. So our buy one, get 3 free, because we treat in 5 fractions, what would have been treated in 25 fractions. So that's a very, very useful thing in a busy department. Before I jump in any further, I'd like to show some statistics of how we perceive hypofractionation and SBRT in India. This was a survey that we conducted, and Dr. Kataria was very much part of this a couple of years back. We looked at 100 radiation oncologists in India who we know treat prostate cancer with some interest. 15 of them already said about 2.5, 3 years back that 15% reported using SBRT already. Low, but I think promising. And 5 centers reported that they use SBRT for more than 50% of their patients. And one of them was ours. So what were the reasons why people were not doing hypofractionation? This is slightly concerning. Almost of all the people who said they were not doing, about half said they are not equipped. Something that we can debate about. And the others, a quarter said that hypofractionation, this is moderate hypofractionation, remember, causes more toxicity. I showed you from CHIP that it doesn't. And about 30% said that they were not convinced that it was better or equal to conventional. I showed you from a 3,000 patient trial that it is. So it's really time for people to move on to moderate for surely. But SBRT, I think if I stick my neck out and say, maybe in 10 years, SBRT will probably be the standard of care for all prostates. Now, I'd really like to touch upon a little bit about the biological rationale. I know you are aware of the low alpha beta ratio of 1.5 to 1.8. So I asked my residents, so what? So what happens if it is low? Now, I'd like to just demonstrate that as a little bit of a teaching here. So these are examples of three normal fractionations that we use. We know they are equi-effective dose, 74 in 37, 2 gray, 60 in 20, and 65, 36.25 in 5 is the SBRT fractionation. Now, remember the rectal alpha beta is assumed to be 3. And with that alpha beta, the BED for conventional fractionation is for rectum is 123, 120, and 106 for SBRT. Now, the magic starts to happen when you start reducing the prostate BED. Assume that it was like head and neck, 10 for a minute. The BED for prostate would be 89 with this, 78 with this, and a pathetic 62 gray for SBRT. So clearly it won't work. But if you reduce the alpha beta to 2 or 1.5, that is when the BED starts to increase. And as we see here, look at the difference, the therapeutic ratio that increases. This is why we say the therapeutic ratio increases. The prostate BED, the rectal BED reduces, whereas the prostate BED increases as you reduce the alpha beta. And that is where the chance of an increased therapeutic ratio and a ability to deliver a higher dose to the prostate. Okay, I must thank my colleague, Dr. Priyamvada, for getting this out from the literature. I had not seen this. SBRT is not new. It started in the UK almost 3 decades ago. You can see here, this is the data published in Urology in 1990. 6 fractions, 6 gray over 3 weeks. From 1962 to 84, and they said that it looks that excellent results were there, and this was probably even 2D RT. So it started a long time ago. That was the historical perspective. Now the first trials really started coming out in the mid 2000s. So 2007, this is a trial called SHARP. They treated 33.5 gray in 5 fractions. The first trial published, 40 patients only, reasonably good toxicity. You can see here the patient is lying prone. These were the days of step and shoot IMRT. We do not use that very often. Most of you would be familiar with rotational IMRT. I have kept this table to show you that the patients were treated with 6 fields, and you can see a couch angle. So this is essentially non-coplanar field. So just a historical perspective again. But the real data started coming in just later this decade. And the first large publication was from 8 institutions. This work was led by Dr. Christopher King from UCLA. 2013, and this really showed the world that look, 1,100 patients have been treated with 36.25 gray in 5 fractions. Most of them are low intermediate risk, very few high risk, a median follow-up of 36 months, not very, but 1,100 patients were already treated around the world in 8 institutions. Excellent results here, comparable to historical series of similar patients. So it gave confidence that we can go ahead. And this is a snapshot of the trials that are actually happening right now. This looks a very busy slide, and I'm sorry it is, but this is important. And I'll take you through this to give you an idea of what is happening in the world and where we are heading and how we are contributing to this. Now, the first one, if you go from left to right, it is arranged in an increasing order of stage and risk group. So low, intermediate, unfavorably intermediate, and high risk. And our own trial is on the rightmost, called Prime. I'll show you more details. This is high risk and very high risk node positive disease. Large numbers of patients. You can see the test arm in all these are almost identical. In fact, they are identical. 36.25 is being compared to either conventional or moderately hypofractionated regimens. Primary endpoint is almost identical in all, including ours, and they are all estimated to be completed in the next few years. Two trials have completed accrual. One is published, other one. So hypo-RTPC is the only trial that is published results. PACE B, I'll show you, have published acute toxicity. Rest all are enrolling, including ours. We have just enrolled the 207th patient today or yesterday. Now, this is level 1 evidence that SBRT in prostate cancer is effective in intermediate risk prostate cancer. This is called hypo-RTPC, 1,200 patients, almost all of them intermediate risk. 78 in 39 versus 42.7 in 7. Mind you, this trial started in 2005. Most patients were treated with 3D CRT. So remember that. This was a non-inferiority trial. Excellent results. Both we have quite a good follow-up here. And so it is as effective as conventional fractionation. Is it safe? Yes. Almost identical GU and GI toxicities, which were low. Remember, most of these were 3D CRT. Toxicity and quality of life are in both arms. The quality of life worsened slightly at the end of treatment, which is what we see. And it came down to baseline and remained there after that. So level 1 evidence that it is effective and it is safe. This is the only other trial that has been published. It is called PACE B. This is led by my former colleague and friend, Nicholas Van As, at the Royal Marsden Hospital. They are comparing nearly 900 patients, 78 in 39 versus 36.25 in 5. And they have only published early toxicity. You can see here, toxicities are pretty similar. So what you should remember is, although the grade 2 toxicities are similar, the SBRT toxicity comes slightly early. It comes at about 2 to 3 weeks, which is an important practice point as compared to moderately hypofractionated. It comes to 4 to 5 weeks. So this is a practice point because the patient should be called back at about 2 to 3 weeks to review in the OPD the toxicities. Okay, but this is all intermediate risk, low risk. We really don't see, I'm sure you see more low risk patients, intermediate in Medanta because of the different patient profile. We really don't see it as a group in India. So we see high risk, we see T3, T4, very common. We see node positive and see our surgeons love to do TURPs. So we see a lot of patients who had TURPs. So is SBRT feasible in these patients? Importantly, do we need to treat the pelvis in SBRT? Now, I must show this to you about treating the pelvis. This is not SBRT. This is moderate hypofractionation. Most of you would be aware of this recent publication in the JCO. This is called POP-RT trial, proving that pelvic radiotherapy is essential while treating high-risk prostate cancer. We'll come to SBRT in a minute. So this trial design was like this. 224 patients were randomized to prostate only or pelvic radiotherapy. All received ADT for 24 months, and all of them had a lymph node risk of more than 20%. We found a large and significant difference in in the outcomes, primary endpoint of biochemical failure-free survival and disease-free survival and metastasis-free survival by treating the whole pelvis in node-negative high-risk prostate cancer. There is no difference in overall survival yet, but hopefully in the next 3 or 4 years, that will also change. So this sets the ground that high-risk patients need pelvic RT. But what about SBRT? Do we need to do that in SBRT as well? So people have addressed this question, not in a randomized manner, but our Canadian colleagues looked at 2 trials of SBRT. See, one was called PHEART and other is called Saturn. One treated ENI, elective nodes, and one did not. Both of them had 30 patients. All of them received 40 in 5 and with or without 25 in 5 to the pelvis. And you see here on the right, if there was no ENI, the failure started to happen. So it does appear that even if you do SBRT, you need to treat the pelvis. But the pelvic story in SBRT actually had a rather tumultuous start, if I may say so, a rough start. This is a trial called FASTER, again Canadian. They treated 40 in 5 to the prostate and 25 in 5 to the pelvis. And a whole lot of things went wrong with the study. You grade 3 toxicity due 26% to 30% 6 months toxicity, and the trial had to be terminated because of this high toxicity. A lot of things went wrong. While that was happening, we had also started treating patients with high risk. This was not in a trial, in our own practice. So we published this about 2-3 years ago. 68 patients at that time. This was the largest data of high-risk patients. Most of them received, all of them received 35 to 37.5 gray in 5 fractions, along with some ADT. And we very gratifyingly found that the toxicity was really low. It was not like FASTER. So we were worried. Many of them did receive pelvic radiotherapy as well. So you can see here under 5% grade 2 toxicity, late toxicities. This is high-risk patients, and very few patients had grade 3 toxicity. So it is possible to treat SBRT and pelvis. So this is the other study from Calcutta, Indraneel's paper called the SHORT. This is a prospective study, so better data. 30 patients, small study. All of them received 35 in 5, but they treated once weekly. And I'll talk about weekly versus daily later. A majority of them, 2/3 of them received pelvis also, and you can see the toxicity is quite low here, grade 2, 0, 2 patients, etc. So again, proving again from the second data in India that yes, you can treat high risk, yes, you can treat pelvis, and yes, the toxicity can be low. So what went wrong with the FASTER study? Couple of things at least. The constraints were pretty loose. I don't know for what reason, V35 less than 30, V of a rectum less than 20, we are at, and this other study, Saturn, had much tighter constraints and it didn't have problems. Our constraints much tighter, V35 less than 3%. So we really push our physicists to have tight constraints, and so the low toxicity. So you can see what went wrong: poor constraint, poor choice of dose, probably larger margins. So a whole lot of things went wrong in the initial part. The most recent data, and again, this is by chance called SHARP, which was the first trial. This is led by Dr. Amar Kishan. We were lucky to be part of this, and my research fellow Tejashri helped me with this data. This was a pool data of 344 high-risk patients. All are high risk in this. All of them had a decent follow-up. And you can see the 4-year biochemical failure-free survival and distant metastasis-free survival, nearly 90%. So excellent control and metastasis-free rates and low toxicity. You can see here under 5%. What was importantly found is even when you do SBRT, the patients in whom ADT was used, they benefited. So 2 things get proven here. In spite of doing SBRT, you need to treat the pelvis, and in spite of doing SBRT, you need to use ADT. So Those two things are important points. Now, we also see node positive disease. We see a lot of node positive patients. I'm sure you do that in your centers as well. So is SBRT safe? Is it feasible? How do we do it? How do we are really fortunate to use so much PSMA PET in India that the Americans are really jealous of us. The whole world is jealous that these guys do 3, 4 PSMA PETs for each patient. So how can we use PSMA PET to improve or to optimize node positive SBRT? So this is a classic example. PSMA PET at baseline, you see high uptake in the prostate, high uptake in the nodes here, very classic. You treat them with some ADT for 4 to 6 months and repeat a PSMA PET. More often than not, almost 80% of the times, the node would have disappeared and the prostate uptake remains. So this is something that we noticed about 4 or 5 years back, and based on this, we developed a treatment schedule that we, so this is another example. We boost the node if it remains, or treat the pelvis prophylactically if the node goes away after ADT. So using this methodology or treatment philosophy, we published this. Again, Tejashri was involved in this. We published this data of, this is the largest data of node positive SBRT till date. There is no other data of 60 patients. All of them had ADT at diagnosis for about average of 6 months. We repeated a PSMA and then did SBRT to the prostate and to the pelvis with or without a boost if the node was present. And pelvis got 25 in 5, prostate got 35 to 36.25 in 5, and the node, if it was present, got anywhere between 30 to 35 gray in 5 fractions. That's SIV. What did we find? Median follow-up was quite good of 30 months. We have reasonably good outcomes here. These are node positive, remember, many of them will fail biochemically, but overall survival is about 90%. Toxicity, importantly, was low. You can see here, grade 2 acute is about, GUGI is about 5 to 7%, and late is about 3 to 5%, which is very much in line with what is seen in the international literature. Two interesting findings we had in this node positive patients treated with SBRT. A cohort of patients had surgical orchidectomy, and others had ADT, medical castration. Those who had longer castration did better. So orchidectomy seems to have, again, hypothesis generating. It seems that you need longer ADT for node positive. And those in whom we treated with a PET-based nodal boost seemed to do better. That is the top line. So interesting data there that you can actually boost and they'll do well if you do that. Now, the other problem that we have in our country is TURPs. So it's so common to see. From the POP-RT data and our currently ongoing studies, we know that about 25% of the patients who undergo radiotherapy, radical RT, have a TURP before. So can SBRT be done in these patients? So to look at this information, we this work was done by my my registrar and now consultant here with us, Shwetab. So we looked at 100 patients. 50 of them had a TURP, 50 of them did not have a TURP, and all of them had SBRT to the prostate. We matched them for a couple of factors like diabetes and the volume of radiotherapy. And what we found was we only looked at the GU toxicity. Those who did not have had a TURP seemed to have a modest increase in urinary toxicity. This was not statistically significant, but it nonetheless increased. The late toxicity occurred sooner in patients who had a TURP, 10 months as compared to 16 months. So there is some effect of TURP when you are doing SBRT. What we also realized was there has to be caution while treating with SBRT, especially if the TURP has been within 6 months of RT. Patients with multiple TURPs, better not to do it, please avoid it. And we started, after we looked at our own data, we started rigorously evaluating patients for pre-existing strictures, because many of them already have existing problems, and you go ahead and do an RT, and then it is all blamed on the radiation. So we have to evaluate them before RT, whether they have any strictures, and I'll show you some methods by which you can do that. Many of these questions about SBRT in high risk is going to be answered probably in the next 4 or 5 or 6 years by this trial that is being ongoing right now. This we are doing in conjunction with our colleagues at TMC Kolkata. This is called PRIME trial. I showed you in the first table. This is a prospective randomized trial with a non-inferiority design in patients who have high risk and or node positive prostate cancer. Standard arm is 68/25, which was our standard arm in POP-RT, and we treat the pelvis now after the results of POP-RT trial. And the experimental arm is 36.25, SBRT and pelvis as well. So 5-year biochemical failure-free survival is the endpoint, and we are at about 210.7. So this will answer a lot of questions. Coming to some practical aspects. I think simulation is probably the most important time one has to focus at to make sure that SBRT is a success. We don't use a lot of things. You may or may not be using it. We don't use ORFITs, we don't use backlocks, we don't use gold markers, we don't use balloons, we don't use spacers or IV contrast routinely. But what we do use is, and this I'm talking only for SBRT, we ensure a strict bladder protocol of moderately full bladder, although it's a different matter that we are now trying to do it in empty bladder, but I'll leave that for another day. We make sure that the rectum has no gas. So we give a patient an information sheet about the kind of diet that they should take. What does it mean by low residue or low fiber diet? Many of them don't understand. So we've written down a list of stuff. We make sure they are comfortable. If the AC is too cold, we make sure that they are warm, and we make sure that they are relaxed, and they just use a knee rest and do use the CT MR fusion. So each of these things that we don't use, we can argue about it, discuss about it, but that is what we do. IPSS, or International Prostate Symptom Score, is a score that we routinely use and rigorously use before every simulation. This, if you are not using, I urge you to not only use this in SBRT, but all your prostate cancer patients. It has got 7 questions about their urinary function, and it can be in a easy way divided into FUN and PISS, FUNPISS. So it's a very easy way to remember whether this is irritative symptoms or obstructive symptoms. And it is important to understand that and address those problems before starting RT, because it's very easy to blame radiotherapy afterwards for every pre-existing problem. So make sure you use IPSS in all your, it's a little tricky to ask these questions to patients, whether half the time the problem is there, or more than half, or less than half, or less than one in 5 times. But over a period of time, you do develop the skill to do it. If you are not aware of this, SBRT contouring is no different from IGRT or IMRT or any other prostate contouring. And please look at these guidelines. ISTRO-ACROP published a couple of years back. It gives very nice tricks and tips about how to contour. So I'm not going to touch upon that. One easy, or rather one important point is identifying the apex, which is, I find, the most difficult part for most of my residents. They struggle, and they make the prostate, and it kind of extends down like a funnel, but that is not the case. The apex has to be correctly identified. If you can't do it, the easy way to is find the penile bulb and just go about 0.5 to 1 centimeter above that and stop your prostatic contour. So that is one way to do it. Other way to do it is look at an MRI, CT MRI fusion. This is full of pitfalls, but you have to get it. Again, it's not as easy as fusing a head and neck or a brain CT MR. It's a little bit tricky here. You can see the apex so beautifully on the MR here. You can see the prostatic apex. You can clearly not see it here. And when you fuse it, you can beautifully use it for delineating the apex accurately. It's particularly important for SBRT to get your volumes right. It may be well contoured. You can see here on the MR, you can see beautifully the volume. But when you fuse it with the CT, sometimes what happens is it doesn't fuse on every slice, and I would call that an inappropriate contouring. This is a miss. That the contour should include all that. So a lot of pitfalls with CT-MR, but make sure you look at the guidelines. Image guided radiotherapy, there is no question, I don't have to tell you, is mandatory for every fraction with SBRT, and this is a classic example of a good image guidance and good match. So many things can go wrong. So make sure you do image guidance with every fraction with SBRT. What PTV margins to take, that really depends on what kind of imaging you're using. We use for SBRT 5 mm all around, especially for high risk. I would not go less than 5 mm unless you are using a whole lot of things like spacers and intraprostatic fiducials or intrafraction tracking, for example, what you do with CyberKnife. So with standard VMAT based or rotational IMRT based image guidance, CBCT based kind of bread and butter stuff that 80-90% of people will do, I would strongly recommend against going less than 5 millimeters PTV. This is just a snapshot of the kind of dose constraints we use. We are pretty tight in our high doses. We have optimal and acceptable schedules. This is all what we use in the trial. So don't have to worry about this. I can send it to you if you want. Now, the other question people ask is, should you use alternate day or should you use weekly? This is a trial done by Andrew Loblaw from Canada, published 2-3 years back. It's called Patriot. They compared every other day versus once a week. And they found that all of them got 40 in 5. And I'll talk about the dose in a little while. And the patients who received once a week RT had slightly better bowel QOL than those who received every other day. But over long term, there was no difference in toxicities or biochemical control or overall survival. So interesting data there. You can use weekly if you want for patients who come from far away. They have to travel 1 hour, 2 hours every day. Don't call them every alternate day. Please feel free to call them every once a week. Absolutely fine. And very interestingly, I must tell you, in the PRIME trial, we are treating in TMH, we treat alternate day. Indranil is doing in Calcutta, he's doing once a week. So we will get prospective randomized data from there as well in the next few years. So bottom line is, it's okay to treat once a week. Now, what is the right dose? Does it matter? I showed you the trials. All of them almost are exclusively using 36.25 in 5. There are a lot of debate going on about whether that is the right dose or not. That EQD2 is about 90 gray. That's fine, even for high risk. People have used, a lot of people now believe 8 in 5 is probably the right dose. And MSKCC, as usual, have escalated it to 9 times 5. So that is 45. So how do we look at it? This dose escalation study from MSKCC from Zalewski, you can see they looked at 32.5, 35, 37.5, 40 gray, and the 5-year biochemical failure free survival kind of improved with increased dose. And they also did a biopsy at 2 years. And you can see here the biopsy positivity rate at 2 years was lesser if you use 40 gray in 5 fractions. So biopsy positive doesn't mean they are going to fail or are not going to fail. It is a poor surrogate for that. So keep that in mind. Clearly, the toxicity was higher with high dose, but biopsy positive rates and biochemical failure was lower with 40 gray. They also looked at the PSA nadir values in two trials that have P-Heart 3 and P-Heart 6, 35 in 5 in one trial, 40 in 5 in another trial. You can see the PSA goes lower when you do the higher dose. So PSA nadir is better. But so is the toxicity, 26 versus 8%, 24 versus 5%. That is between 35 and 40 gray. So if you do 40 gray in 5, like many people claim in the West, the toxicity is going to be much higher. And especially if you don't use a number of accessories like spacers and balloons and tracking, I would strongly urge you against going beyond 36.25 in 5. That is a safe dose. You can do it without much problems. Talking of spacers, I don't know if you use it, but this is creating a lot of waves now. It's a polyethylene glycol that is inserted between the rectum and the prostate to create a space like that. And there's actually a randomized trial that said that if you use a spacer, the dosimetric parameters are better. You don't need a randomized trial to tell you. I can tell that without even a trial. Of course, it is going to be better. The toxicity was lower, but if our toxicity is already 5% grade 2, really, do you want to lower it further by inserting some stuff between the rectum and the prostate? That is a question you have to ask yourself in your practice. I would think no. There are other problems with spacer, obviously cost, invasion, and it has limited use in high risk, which is what we see. It is useless in re-radiation because you don't get the planes. And it is, first of all, not available in India. We are looking at putting in spacers using hyaluronic acid. We have written up a study. We're just starting it using patients' own blood. We'll see how that goes. We've just started using endorectal balloons. We don't use it routinely. This is very simple to use. They're quite expensive though. What they do is they immobilize the prostate. They reduce the volume of the PTV of the prostate by compressing it, and it removes a lot of the rectal wall out of the high dose region. So again, not mandatory, but you'll need to use all this if you're using a dose beyond 36.25 or 37 gray. Now, can we go less than 5 fractions? Well, it is possible to go less than 5 fractions, but as I said, you need to use all this accessories to be able to safely do that. People have started looking at 3, 2, or even 1 fraction. Now, this is very interesting. We are also gradually moving in our at least minds to 3 fractions now, and hopefully on the protons we'll be able to do that. I'll show you, but I really urge you not to try this because it is completely experimental. And I'll tell you why it is experimental. I'm not for one moment doubting your ability to deliver the 1 fraction if you want to with all the technology at your hands. This is a randomized trial very recently published about just 2-3 months back called Prostate, phase 2, small numbers. 30 patients, they randomized to either 24 in 1 or a very high dose 9 into 5, that is 45 gray. So that's a very high dose of SBRT and very, very high dose of single fraction, 24 gray in 1 fraction. It all appears same if you look at it statistically, but if you look at it, this is the biochemical failure-free survival. If you look at the numbers, these are unfavorable intermediate risk, remember. With SBRT, the 4-year biochemical control, 75%, and with single dose, it is only 64%. So clearly something is not right. This is too low for both arms, particularly with single dose radiation. So clearly there is something in the biology that it is asking for the second dose at least. So 1 dose is clearly not enough. This is what this trial shows, although numerically they are the same. Now there is a big talk about giving a DIL boost with SBRT. There is a trial called FLAME that has used up to 95 gray, but in conventional fractionation. And there is now a lot of interest in giving a boost to the dominant intraprostatic nodule. You can see here as seen on MR to give that a higher dose. And to do the DIL boost, it is important to identify the urethra because you may end up treating, giving a very large dose to the urethra. MRI can be used for urethral delineation, and it is excellent work by our colleagues at Medanta to have shown the right way in very detailed manner about how to go about delineating the urethra. So this is really, really useful. And so finally, yes, SBRT for even for high risk and TURP, etc., is possible, but the devil is in the detail about the margin, about the dose, what kind of image guidance you use, how to treat the pelvis safely, what kind of constraints you give, and what is the dose you give to the PTV or CTV, etc. So with that, I will end. Thank you. Happy to take any questions.
Thank you, Dr. Vedang. As always, brilliant lecture. You started very nicely from the basics of PED and then almost touched on all important topics that anyone will like to hear in SBRT prostate. Especially talked about the high-risk SBRT cases, not forgetting ADT, and especially the node-positive SBRT.